I started recording the webinar. I completely forgot to do it from the beginning, so I just started. But so just so you know, it's being recorded now. Okay, so within this article, the researchers have looked at various of articles that really engage the African American population, men, women, and both of the population, and really trying to see what kind of intervention do they respond to, what kind of intervention work well with the specific population. So they look at various researches, and the latest one that was part of the research was up to 2012. So some of the research or some of the component within the research is a little bit, I would say, old, not though outdated, because we are still using some of the information that they discussed in the article, but we will see how these may be helpful in terms of what we do soon, once we go over it. So they have conducted a systematic review of effective intervention that retain African Americans who are living with HIV and in treatment or other HIV management programs that provide them support that they need. The article itself was published in 2015. Okay, so like I mentioned, the article was organized in terms of intervention that work well with African American, and if we see, there's two sections, right, in terms of intervention. The first one is self-care symptom management, and the second is antiviral therapy. And we're going to see what each of them entail in a minute, right? So for the criteria for the researcher when they were doing this systematic review, they were looking for research that included African American person living with HIV, mainly African American people living with HIV, adult women, and both, and focus on engagement and retention, and also medical adherence, right? So then I went ahead and really looked into what the intervention really was talking about, or what the intervention really focused on. And many of the interventions that they looked at focused on outreach. Many of the interventions focused on ancillary support services, and many of the interventions focused on theory and perspective-based intervention, as well as intervention using manuals to manage HIV care. All right, so what do I mean by that? Let's take a closer look. So within the outreach intervention brackets, we have intervention that this was looked at through Cabral and all in 2007. So they did a research where they were looking at populations that were hard to reach, which included low-income MSM of color, adults, homeless, adolescents, women, and substance users, to really participate in the research, right? So as an intervention, they use outreach, advocacy, and support services such as food services, transportation. They were accompanying their client to appointment, and they were also using counseling services as the support services for their particular participant to really attain or be retained in care. And as a result, they noticed that there was an association of those clients that received contact from their provider nine times or more during the first 3 months of being diagnosed, or having more contact with their primary care, or more engaged with their primary care, as opposed to those who did not receive those contacts. So the gap in care tremendously reduced, and the more they're meeting their needs, the more they will engage in the HIV care. All right. Next, we take a look at Narking, and he also looked at He also looked at intervention that really helped the client with medical appointment. They really advocate for the client in terms of getting services that their needs so that they can be retained in care. And there was a 12-month follow-up to enroll in the outreach program, and once they were enrolled in the outreach program and assistance is being provided through medical appointment, having their insurance on point, and substance use services to help them deal with substance use, mental health, and HIV-related stigma, they noticed an increase of care that was associated with the reduction in substance use. So some of the clients were using less substances, and some of the clients were more engaged with the primary care provider, and some of the client rather have more updated with their insurance provider, more up to date with that. So really, through this research, that we noticed that there was 45% of the participants reach undetectable viral load at a 12-month follow-up period through the intervention of medical appointment and all the services that I mentioned earlier. And I just would like to mention as well that within this specific research, 59% of them were African American. And the previous one that I discussed, I forgot to tell you that there were about 44% of them were also African American. Just to give you an idea in terms of how each population will respond to the specific intervention that will be introduced to them. Okay, so next we have ancillary support. And within ancillary support, case management was provided, transportation was provided, mental health and chemical dependency, drug treatment, housing assistance, transportation were all the services that were provided with the hope and with the goal so that it moved African Americans, specifically population who are having hard time accessing care, to maintain them, to engage them in care so that they'll be retained in care. So I'll go over some of the specific interventions that were used in this specific bracket as well. So like I mentioned earlier, case management, transportation, mental health, and chemical dependency were the main services that were provided, and as a result, we see an increase from 15% to 18% in association with the intervention that were provided, as opposed to those who didn't receive any of the services. And here in this specific study, they measure retention in care as 3 to 4 visits to the primary or to the HIV care doctor within a calendar year. So everyone who had 3 or 4 or more visits to the doctor were considered retention or retained in care. Okay, so now we look at Messery research, who specifically also looked at case management, drug treatment, mental health, housing assistance, and transportation, right? And within this specific sample group, there was about 577 sample participants in the research, and 52% of them were African American. And using the self-reported survey, many of them reported that the treatment, the intervention really helped them, get entry to medical care, and it really helped them remain engaged or have engagement with their provider in terms of their treatment, in terms of other medical care that is associated for their treatment and for their well-being. So active case management was related to the association of the increase to medical care here, and the more they have, they have interaction with the provider who are providing case management or drug treatment or mental health services, they're more likely to gain entry to medical care. All right. So now we move on toward the self-care management aspect of the intervention that was introduced, right? And our next research really looked at mothers, right? So all the participants here were African American women who have children, and really how do they cope with living with HIV, right? What were their concerns, what were their needs? And throughout this research, it was noted that stigma was a huge part or a huge barrier to them. And as a result of this maternal self-care symptom management, participant mother in the experimental group reported fewer feeling of stigma and higher physical functioning and reduction in depression and anxiety. And this was done having interaction with the mothers. So during the research, nurses were designated to really implement this intervention. So they had home visits, and during the home visit, they were discussing needs, the mother's needs, and how to really approach those needs, how to cope with some of the symptom or anxiety that they may have when it comes to relating to living with HIV, and really what are the strategies can they come up with together with the nurse with them to make sure that they attain their goal. As well as after the nurses leave, there was follow-up calls to make sure that everything they discussed were maintained and attained. Knowing that the nurses were going to the home of the participant, it was highly, and knowing the discussion of HIV and how it was perceived with others, nurses did not mention the word HIV once they were in the home or if somebody else was at their presence during this particular intervention sessions. They rather referred to as women's health to discuss all the topic that they were discussing or anything that they were discussing. It was referred to as women's health. And as the intervention was also embedded with therapeutic relationship between the mother and the nurse. So one aspect that I really like about this specific intervention was that it had several underlying elements to improve knowledge of HIV and really identifying health problems and seeking help earlier and really remain engaged with the provider. So those were some of the elements. In addition to that, the nurses were accepting of their participant condition of living, whether where they live or whether they're living with their family. They value all the participants in terms of the perspective that they had about their illnesses. They use certain critical skills that we all may be familiar with, such as reflective listening and really reinforcing the steps that the participants are making to improve their life. They've also used reframing that we often talked about. Those of you who know CLEAR and the element and the core element of CLEAR. So I see some of those components here in this particular study, and they use reinforcing and reframing. Role playing was also involved in problem solving and really focusing and understanding HIV and self-care strategies. So those were the key points in terms of this particular study. All right. So the next, when this was with Corliss, he specifically looked at, he was a longitudinal randomized controlled trial where participants living with HIV expectation is able to perform certain behaviors successfully. So the participant really, they were assessing, so they were given tools in terms of manuals and how to manage the symptoms and how to manage living with HIV. And the research were looking for how everyone was responding to really managing the manual and how they were using the tools that were being provided to them through the manual. And as a result, they noticed that those who have low self-esteem were not really engaged with the manual as opposed to those who had higher self-esteem. And through this research as well, they noted that women were more likely to have low self-esteem. Black women specifically, or African American women, were more likely to have low self-esteem and were not really engaged with the tools that are being provided to them. Okay. Now we move on to the structural ecosystem therapy. So the structural ecosystem therapy also looks beyond the individual and trying to view what else is impacting the life of individuals living with HIV and how they can gain support beyond, within their circles, within the family, beyond the self. How can the community also get involved in supporting them living with HIV? So this specific intervention looks at the efficacy of structure of ecosystem therapy. Again, these also engage nurse practitioners, and it was a longitudinal study of African American women. Mainly, all the participants were African American women, and the goal of this specific intervention was to target maladaptive family or interpersonal interaction between family and other important systems such as healthcare providers, right? So the goal was to address interactive with their family member and how they can get support to gain a healthy lifestyle or to support or to really build and establish healthy relationship within their surrounding. So one, they focus on gaining entry back to their family, so those who are not really close to their family, to gain back entry to their family and building trust with their family member. And two, they really look at identifying the pattern of interaction with their families and to really identify which were maladaptive and which were beneficial to their health. And three, they looked at restructuring that interaction now, really in restructuring that relationship to see how they can make it positive so that it can in turn be supportive to the participants who are living with HIV. And we see here as a result of this specific intervention, more participant adherence increased to 95%. Okay, now we're specifically going to look at antiretroviral therapy and adherence to medication. Here specifically in Bogart's research, they looked at a treatment through advocacy program that aim to engage clients into care and support antiretroviral treatment. And participants who receive advocacy or who are part of the advocacy program meet all their social needs, right? So all the needs that they may have, the one that I mentioned before that were part of the outreach program. So if they need transportation, if they need housing, if they need mental health, if they need assistance with treatment, drug treatment, those who receive those services were adherents to care and they were engaged to care. And 40% of the population or the participants in this specific study were African American. Okay. Now we're going to move on to another intervention that was used, that was deemed effective as well, with the ready intervention using nurse clinicians as well. And here we see that the nurse, and within this specific intervention, they focus on, engagement and adherence to medication. And at the 12-month follow-up, they did a follow-up to see how those engagements were maintained over time. And as a result, 50% of the participants became adherent to ART, and at a 12-month follow-up, 79% of them remain adherent to care. So some of the key points in this particular intervention that I really liked was that the intervention really reevaluated the lifestyle. They helped the participant identify barriers that was, contributing to them not being engaged in care. And together, they were creating strategies through goal setting for them to meet those specific needs that they may have. So really, we see that this had both the engagement of the provider, who were the nurse at this particular research. They were engaging the participant to be involved in the process that a need for them to reach and maintain in care, or so that they can attain adherence with medication. Okay, so we're going to take a look at the next. This particular intervention it started back in 1999, so it's a little old. I acknowledge that. However, I think it has a great component that we can all pick up and really see how we can integrate it into something that we're currently doing. So they created a support group that were composed of all African American women who were living with HIV, but specifically those who had low literacy level. So within this support group, they create with African American women, they were looking at how do we provide services, or how do we provide resources for African American women with low literacy to have access to certain services or to have access to certain resources rather, that will help them navigate and really manage their living with HIV. So at the end, they created, the support group met for a few times, about 5 times through a course of an intervention, about 5 years, I believe. And they created a cartoon book and a cassette tape at the end, which is the resulting materials that came out of this, and really to provide everyone or African American women specifically, who may have low literacy level, to have access to information. And the information that was included in the book on the cassette were people like them, uses language like them, and really address certain information or certain barriers that they may encounter. So the book addressed perceived susceptibilities, perceived severities. So how do they perceive living with HIV? Also, a access to knowledge in terms of HIV and living with HIV. Outcome expectation, So living with HIV, what is their expected outcome? How did they perceive that to be, living in a particular area or living with certain limited resources? So, and also included language that they find that many African American women use to convey all of this information in the book. I was looking to see if I will have access to the book to present, or to have the cassette tape so that maybe we can hear some of them. but unfortunately I couldn't find it. Okay. So next we look at another research that Gardner did, and this one was specifically looking at antiretroviral treatment access studies, right? So again, up to 5 contact with case management with linkage to care over 90-day period was provided, and was mainly for newly diagnosed patients or person, and 59% of them were African American. So there was about 316 participants in the study, and the intervention looked at African Americans specifically, and 59% of them were African American, and they were really looking at how active case management for linkage to care, or those who are just newly diagnosed, how does that affect their engagement and retention in care. And at the end of the study, they noticed, or there was an association between the service provided and those who remain in care. So we see that participant older than 40, but this specifically is talking about Hispanic, newly diagnosed without recent crack cocaine addiction, were more likely to have 2 visits with a provider. So by receiving some of these case management services, we see that they're having more visits with their primary care provider or with their HIV care provider. Okay, so we see on the next research done by Weaver, where we looked at cognitive behavioral stress management, right? So we all know everyone we all have stress that are impacting our daily life. We all have stress that affect our health, whether it's mental, physical, and spiritually. And within this specific research, coping mechanisms were provided to the participants so that they can use resources to cope, to change your mood, to cope with certain strategy. So the certain strategy coping mechanism were given to them to manage the stress level that's associated with living with HIV. And as a result, we see that lower social support, those who had lower social support was associated with greater use of avoidance coping strategies, which result in poor adherence and high viral loads. And as you can see, those who had higher support were more likely to be retained in care or to be adhered to medication, as opposed to those who have low social support. But within the intervention, resources were given in relation to how to cope with the stress, how to alter the negative mood, how to utilize social support, and how to be adherent to medication and lower the viral load. Okay, so this is the end of all the effective strategy or intervention that Gaskins and all have provided within their article. And really, the interventions, many of them are not new to us, and some of us have been using this type of intervention for years now. But the goal of this webinar is to how do we take this intervention and use it maybe in a different way, so that we can be more responsive to our population than we probably were prior to how we were utilizing them, right? However, some of the research come with limitations. And as I was stating, some of the populations that were involved in the research throughout, as I was going over the specific research, some of them had very low sample size, meaning the number of participants within the research were not big. so therefore it limits generalizations. And some of the intervention did not fit the CDC criteria for evidence-based intervention, so that you cannot replace, if you're currently using any ABIs from the CDC or you're funded by the CDC to provide or to implement certain ABIs, you should not replace those by this intervention that I mentioned. However, through this information here, through the specific intervention that was provided through us, through the research that Gaston and Al did, how do we then take this information and tailor to what we're already doing, right? How do we then take this information and really take a look at the need that we have with our specific population within our specific location? How do we then take that, how do we manufacture that to a new thing so that we can respond to our population needs, so we can respond to our population's services, the services that we're providing them. And we can still meet our grant deliverable at the same time. And we can still, meet our, the intervention or the ABIs that we have been funded to do, so that we don't lose any of our funding. So here are some of the limitations to the articles. And then the next step here, the next aspect is we're going to hear from Sarah from Christie Place and see how she utilized the intervention or some of the strategies that she has within her organization. We're going to see what are those interventions that she utilized and how this intervention work with her specific population. Okay, so this is Sarah, and I'm going to, Sarah. Okay, so Sarah, I see you as a presenter. So how do I unmute you so we can all hear you?
I think I got it.
Okay, great. There we go.
Hello, everyone. First of all, I just wanted to really thank HOPE and the Latino Commission on AIDS, as well as the CDC, for inviting us to present in this really important webinar today. So let's see if I can figure out how to move slides. There we go. So that's my contact information. It will show up again at the end. So Christie Place is a leading nonprofit community-based organization in San Diego County in California, and we provide comprehensive HIV/AIDS education, support, and advocacy that is situated within a social justice framework. Our mission is to empower women, children, and families whose lives have been impacted by HIV to take charge of their health and wellness. We deliver trauma-informed, comprehensive social and behavioral health services that are closely linked to HIV primary care for people living with HIV and their family members, with a focus on women, children, and families. So this is a slide of our continuum of services. We are a very small staff of 16, and so you can see that we have quite a few services. These include medical case management, behavioral health counseling, peer navigation, and a comprehensive drop-in center. This is all provided along with a myriad of other services that help support and engage women and families in their health and well-being. So this slide is not meant to be all-encompassing or an exhaustive list of the barriers that we see with African American women and our clients in general, but it is meant to just provide some context for the following conversation. So Hope really covered a lot of this at the beginning of the webinar, and so I'm not going to go into too much depth on it, but we have seen that there are there are huge concerns regarding confidentiality and overall mistrust of the medical system, substance use and mental health conditions. And for a lot of women in particular, economic and financial status and lack of child care, transportation, food, and food insecurity. So basically, their basic needs are really taking precedence over looking and engaging in care. Excuse me. So we also see that a lot of women living with HIV are impacted disproportionately by trauma and PTSD. And the research really backs up this anecdotal thing that we see. And this is something that's true for all women living with HIV and other populations that are living with HIV. So trauma and PTSD really impact at disproportionate rates. In fact, the rate of recent PTSD among women living with HIV is 5 times higher than the rate of women within the general population. And the rate of intimate partner violence and childhood sexual abuse and childhood physical abuse all occur at double the national rate among women. So the reason that this matters is that trauma and PTSD actually predict poor HIV-related health outcomes, such as poor health-related quality of life, higher rates of medication non-adherence, and even when women living with HIV that have histories of trauma are actually adhering to their medication, they still see higher rates of antiretroviral failure. This obviously leads to higher mortality rates within this population. So what do we do about it? At Christie's Place, we really have taken a trauma-informed care approach to the work that we're doing. Trauma-informed care is a resilience-focused and strength-based approach to service provision that involves understanding, recognizing, and responding to the effects of trauma. The Office on Women's Health have 4 qualities of a trauma-informed system of care. They include intentionality, so that really means that you're being purposeful in creating and sustaining environments for healing and growth. Mutuality, so the connections that providers and service recipients have are really reciprocal. That means that both parties are actually getting something from that relationship. Commonality, so life experiences shape our perceptions of ourselves and others and the world around us. And potentiality. So positive change is positive for all, and this includes individuals, organizations, and communities. So at Christie's Place, we have taken these 4 qualities from the Office on Women's Health, and we have created our 6 core components to trauma-informed service provision. So core component number 1 is agency and empowerment. So we're fostering integrity, respect, and dignity for service recipients and providers. And we're really supporting a belief in one's capability to heal and recover. Core component number 2, which I will get to highlight at the end of my section here, is the meaningful inclusion of women living with HIV. So this is really creating an emphasis on recruiting people living with HIV for not just volunteer positions, but also for staff and board positions as well. Core component number 3 is education and support, and includes ongoing training for service providers and service recipients around the impact of trauma on communities of color and others. And this includes cultural and historical and structural traumas as well. Core component number 4 is stakeholder investment. So we really found it vital to obtain the commitment toward trauma-informed care from management staff, clients, and our board of directors, as well as local and national communities. And core component number 6 is trauma-informed environment. So that's actually Christie's Place that you see here on the slide. We have a working kitchen that anyone, staff, or service recipients or other providers can come in and use. We have a child care room, and a lot of our spaces are specifically carved out to be child friendly. We are literally a house and a mixed residential and business location, and we are intentionally non-identifiable so that stigma doesn't really come into play when it comes to accessing services at Christie's Place. We are like any other house. And then core component number 6 is really having intentional practice. So our practices are based on an understanding of how the effects of violence and abuse exist within the context of women's lives and the intersections of their identities across the lifespan. So again, this is where that cultural and historical and structural trauma really comes into play in understanding how women's lives are impacted by violence and abuse. So as I mentioned, I'm going to highlight the strategy around peer navigators and the meaningful involvement of women living with HIV. So peer navigators are really key to our trauma-informed model of care. They conduct community outreach and case finding. They also do both informal and formal assessments for barriers, psychosocial needs, and basic needs assistance. They conduct home visits, and they also can accompany clients to their scheduled appointments, and this could be social services or medical appointments. They do provide transportation, both by taking service recipients to their medical appointments, but also by providing bus passes and things like that. They can provide translation when necessary and substance abuse counseling when necessary. And they also provide emotional and peer support, health education, healthcare navigation, information and referral, and they refer to case management and trauma-responsive behavioral health services that all exist within their structured program as well. So one of the highlights of our peer navigators is that they really work within the social cognitive theory to be able to role model what it is to live well with HIV. So our peer navigators are women who are living with HIV, who have gone through extensive training to be able to work within healthcare and social service settings. And I'm very proud to work alongside 2 of our peer navigators here. This is Martha actually in the slide, and Jay was in one of the slides earlier. Around meaningful engagement of meaningful involvement of women living with HIV. And so we see that they are able to connect with clients in ways that other providers can't. And they also are able to really put themselves in the shoes of their clients, as well as their clients are able to put themselves in the shoes of the peer navigator. And so they work within again, the social cognitive theory to provide role modeling, and they can also show that commonality that I spoke of earlier and that mutuality so much easier than most anyone else can. So that's about it for me. Again, that's my contact information. If anyone would like more information around trauma-informed care or even how we implement peer navigators within a social service setting. Thank you so much, Hope, and everyone else.
Thank you so much, Sarah. Thank you for all the information you have provided for us. Okay, so now we are going to move on with all that information that was provided. How do we now move forward, right? And this is the references to what Sarah has provided. So what is next? Right? What do we do next? There's tons of information, there's tons of strategies, there's tons of interventions that have been proven to be effective with African American, but then how do we implement them, right? So here I put it in a form or in a framework of the social ecological model, right? I mean, everything that we do is from the individual and back to the society, and we know that as an individual we do not live in an isolated world. We oftentimes come into contact, we connect, we interact with the rest of the society, from those who are really close to us, the community, and into society as a whole. Now, how do we evaluate what we do, and how do we satisfy our grant requirement and still respond to the need of our population, right? So as you can see here on the slide, I put here the HIV Self-Care Symptom Management Manual as an example of some intervention that can be done at an individual level, right? If you're giving them certain tools and we teach them how to use certain tools, then they themselves can learn how to utilize those tools to really effectively manage living with HIV, manage any stress that might come with it, and then manage any other barriers that may come with it. And then there's also the efficacy of structural ecosystem therapy that really dealt with the relationship that people living in HIV have with their close family, the relationship that they have with those who are surrounding them, those who are close to them, right? So how is that impacting, their health behavior, their lifestyle as a whole, So as an agency, we have to evaluate where do we fit in. Where does our agency target through the services that we provided? Are we targeting population at an individual level? Or are we targeting them at a relationship level, to the relationship they have with people close to them? Or are we targeting them at the community level or at the societal level? So, for example, at the society level, we can see some policy that we have in the society, whether who has access to PrEP and where they can find access to PrEP, those type of information. At the community level, we can have, what are the number of services available to my population in this specific community? Is it addressing the need that my community is expressing, or does it even exist at all? So this is where we come in. Based on the information we gather through this webinar, or based on the information we have, and based on the resources that you all have at your respective agency, how do we then put all that together and really analyze where we want to prioritize our services so that our population really have access to the information that they need? And this can bring us to the end, because only you can answer those information. Because I don't know what the type of services you have, I don't know the type of resources you have, but from what we've seen from the intervention that was presented from the Gaston article, we see that retention is successful when participants know their needs and receive assistance accordingly. So when those needs are met, we see that there's an increase in adherence. We see that there's an increase in engagement. We see that there's an increase in retention, where services as housing, substance use, or any other priority that we discussed at the beginning of the webinar. And retention seems to increase with ongoing contact with the support services of provider and the family members. And I'm sure those of us who has experience working with any population, not just the African American population, but service providers or the support system, right? Some of them does not have it. Some of them do not have any family members, and many of them are going through, dealing with living HIV alone. And for providers, we are the only support system that they have. And we see that some of the early intervention that I went over at the beginning, the more contact a participant had with the providers going through medical appointment, or just reminding them that they have medical appointment, had a significant impact in terms of whether they're being retained or engaged with the primary care providers. So we have to keep those in mind as we are evaluating how we are providing services, and know that we cannot ignore those services. We cannot ignore those priorities of our client, and really tend to them, adhere to them, so that we can be, increase. We want to increase and raise the bar of African American community, particularly, so that more of them can be retained in care, and more of them can suppress their viral load, and more of them can live a healthy lifestyle with HIV. And that brings to the end with me Um, Sarah spoke. She gave her contact information. Feel free to contact her if you have any questions. I will give you my contact information at the end as well. All of this information, we don't just throw it at you and then be like, go and do it, do what you need to do. But we are here to provide supportive services as well. Whether it's me or Sarah, you can contact us and request capacity building assistance. If you are funded through the CDC directly, you know what CRIS system is, and you can go into the system and request assistance in terms of how to really then take all this information and apply to your population and how to attend to the need of your population so that they can be engaged and retained in care. Those of you who are not funded through the CDC specifically, you can still receive assistance from us through the CBUP services if you go through your health department, right? So if you contact your health department, and they will be able to guide you in how to put in requests. And those of you who don't know what CBUP is, there's several CBUP providers all over the country, just like the Latino Commission on AIDS, that will provide services for you free of charge, because we are funded by the CDC as well to provide you any assistance that you need to make sure that you reach your grant deliverable. So all those services are free of charge. As long as you provide, you get them through the CDC or the CRIS system, and we'll be more than happy to provide you assistance. At this point, I would like to open it up to questions. If anyone has questions, please use the chat box and write the questions, and I will unmute the line now, and you can use *7 and you can ask your question. Before I unmute the line, there was a question earlier that I didn't see at the time, but I see it now, and it was asking, how do you measure retention and why not use viral load suppression as a measurement since that is the end goal? And this question was asked when we were going over the. Let me see if I can go back a little bit and show you the slide that was showing when this question was posed. Was this one from the CDC, and the CDC measure retention in care with 3 or more visits to the primary doctor, measuring or doing a lab test to see where the viral load is. So that's how they measure retention in care. If you have 3 or more visits to your primary doctor, and if you are continuously taking a lab test to see where you are in terms of viral load, that was how the CDC measure retention in care when creating the specific chart. Okay, so I want you. Anyone, you can write your question in the chat box, or I will unmute the line just momentarily so that you can ask any question to me or to Sarah.
The conference has been muted.
No.
The conference has been unmuted.
It's unmuted now. Any question at this moment for me or Sarah?
No questions on my end.
Everything is.
A few more moments for questions. And you may utilize the chat box as well. No more questions. Send my email address to everyone. Feel free to email me if you think of a question later. I will be sending the slide set after we end the webinar, so you have access to. Right, this is what I just said. So all participants will be providing with the PDF version of the slide set, along with the attachment of the article I was discussing or I presented on with the Gaston et al. Attached to the. I'd like to thank everyone who was on the webinar on this lovely Friday. Thank you very much for spending your Friday, or a little bit of your Friday with me. Again, feel free to talk to either me or Sarah if you have any questions.
All right. Have a safe weekend.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
All right, this brings us to the end. Thank you.